Good morning, you all. This is a small presentation with a problem in the lower leg. I'm Dr. Ravindranath here. The history goes like this. A 60-year-old male patient with a diabetes which is under uncontrolled state, with a road traffic accidents 2.5 years ago, and sustained a compound fracture of the lower one-fourth of the leg, grade 3 in nature. On presentation, he has come with the following radiographs. Uh, Initially, they have done wound debridement and an external fixator was applied. The pin going through the talus also. The bone is exposed at this point of area, and then it is getting gradually lost by sequestration. You can see the bone is getting lost during the repeated air dressings, and he has come with this defect wherein there is no anterior medial wall, there is a lateral wall, and a very weak posterior wall. You can see there is a very weak posterior wall there. The skin is hyperpigmented, indicating some chronic pathology is going on in the leg. What are the management option for this case? There is a soft tissue defect. Can we go for a coverage of the soft tissue? And can we go for internal fixation? Or should we go in for a fine wire frame application or a laser frame application or an amputation? For me, there is no role of amputation here because the skin is defective and because of the hyperpigmentation of the skin indicating the chronic pathology. Since he's a diabetic fellow which is uncontrolled, the vascularity may not be very good. It may be jeopardized because of the diabetes. Soft tissue coverage may not be successful in this case. And there is definitely no role for internal fixation here. We are left with the fine wire frame, that is L0 frame fixation. Because of there are bad soft tissues around, we have put him in a fine wire frame, that's L0 frame, with minimum of 3 wires in the distal fragment, so as to prevent varus collapse and construct the frame very strong and rigid, allowing axial compression. And you also see there is hypertrophy, or we are aiming to get hypertrophy of the lateral column, and if possible, a cross union between fibula and the tibia. Distally, there is a diabetic foot, as evident by this radiograph. After 6 months of time, we can see increased density of the lateral wall of the distal tibia. An attempt of cross union between fibula and the tibia is expected, and patient is started on teriparatide. Of late, teriparatide is helping us like in osteoporotic patients or old age patients. 1 year post-op period shows increased density of the lateral wall, also the cross union between the fibula and the tibia. Patient is still on teriparatide. At the end of 2 years, you can see there is a better hypertrophy of the lateral wall and better union between fibula and the tibia, that is cross union is very much progressing there. After 2.5 years post-op period, we can see there is hypertrophy of the lateral wall of the lateral column of the distal tibia and a good cross union between fibula and the tibia. This was the presentation at before applying the insular fixation, and on the right side is a final picture after 2.5 years of primary injury. You can see the ankle mortise is very much horizontal to the ground. End of 2 years time, this is the gait. The patient is walking independently without pain. He developed some urinary problems during the course of treatment for which Foley's catheters were applied. Patient has got hyperpigmented skin indicating some chronic pathology still going on. maybe diabetic infection, maybe persisting there. That's a clinical picture. What did I learn from this case? Lower fourth of the leg is known as a graveyard in orthopedics because the tibia has got, except the FHL on the posterior side, no muscles around the tibia in the lower fourth of the leg or the tibia. Because it's weight bearing all through, we can expect hypertrophy of the remaining lateral wall of the tibia, and during the process, you can expect some hypertrophy of the cross union. Because of the hyperpigmentation of the skin persisting for a long time, infection is going to persist for a long time, and the patient has to bear with it for a long time. Best wishes to you all, and thank you.